Thank you so, so much, Kate. I really, really appreciate you talking through that. And I know, because from doing research in a similar area, I know just how significant those sorts of behaviours are. So we really appreciate the work of you and of Justin and sort of looking at how we can best intervene with those. So thank you very, very much. And so the final talk of today is going to be from a wonderful researcher from just across town at Aston University. Dr. Jane Waite is going to come and talk about another very important topic to many of you, I'm sure, which is anxiety. And before I kind of hand over the mic, I just have one plea to people that in front of you, you may have noticed there are some feedback forms for today. So before you pop off today, if you're able to do so, we'd be really, really grateful if you could fill in those forms or those surveys and either leave them on the front here, or you're welcome to take them home and post them to us in the office. But we'd be very, very grateful for your feedback. But without further ado, now the slides are up on the screen, I'm going to pass you over to Jane for our final talk of the day.
Okay, I'll perhaps hold it a little nearer. Yeah. Yeah, that's fine. Can you give me a 5-minute warning? Thank you. Okay, so it's absolutely lovely to be here today to talk about some of the work that we're doing looking at anxiety. Most of the work that we're doing currently focuses on people who have moderate to severe intellectual disability or who have communication impairments. When I'm talking through the slides today, I will give some information specifically regarding that group. But we're hoping that the work will also inform the work that we also want to do with people with more mild intellectual disability who are able to express that sometimes they experience anxiety. Okay. So before I get going with this, I just want to mention several people who have contributed to this talk. So by no means is this all my work today. I'm going to talk about a lot of work from Hayley Crawford, who is at Coventry University, and Laura Groves, who is at the University of Birmingham, and they're two collaborators that I work closely with. And also I'm going to be presenting work from Georgina Edwards and Jo Tarver as well, who are part of my team. Now, before going on to talk about the work that we're currently doing focusing on anxiety, I want to just give a background to anxiety and Fragile X syndrome to introduce the topic a little bit more. We've heard already about how anxiety might lead to temper outbursts, and that's certainly one way that anxiety presents in people with Fragile X. But I also want to focus on a broader profile of anxiety that we might see for some people with Fragile X syndrome, where it may lead to an outburst, but it may not. Sometimes it may lead to more avoidant behaviours, refusal to go into certain situations, and other behaviours that might actually get in the way of good quality of life for that person with Fragile X. And then finally, I just want to talk about an update on some very recent findings in anxiety, and then go on to talk about the next directions. Importantly, I'm going to be presenting some figures and facts around anxiety, and it's just really important to say that every child is different. Whilst a high proportion of children and adults with Fragile X do experience anxiety, I also want you to hold in mind that there are a proportion of people with Fragile X syndrome that don't experience anxiety. So if you're a parent of a young family with Fragile X syndrome, there are also some positive outcomes for people, and not everybody experiences very extreme anxiety. There's a whole range of anxiety within the group. Okay, so I don't probably need to give you a definition of anxiety. Most of us know what anxiety is. I think it's really important to say, though, that increasingly anxiety is pathologized, I think, within our day-to-day lives, whereby largely due to the media or what we hear, we may feel that actually any degree of anxiety that we experience is somehow abnormal, or we shouldn't experience it. But actually anxiety is a very, very normal part of life. It's only when anxiety starts to impact on our day-to-day routines, the things that we want to do, as I'm sure many of you who are living with somebody that experiences anxiety will know about, is when we would talk about anxiety as being clinically significant. But it's really important to make that distinction, because when we're developing tools or measures or doing research projects in anxiety, what we want to do is to be able to capture the children that are in most need and the adults that are in most need of support with anxiety. and also to be able to differentiate anxiety, which is the anticipation of a threat in the future. So when we're anxious, we are thinking about something that's going to happen. So we're thinking about something that hasn't happened yet. So if we know that there's a tiger somewhere loose in this building, and it might at some point appear through one of these doors, we might be feeling quite anxious about that, but the threat may not be immediate. Whereby if you didn't know that there was a tiger and suddenly one appeared in the room, that would be fear, because the threat is very immediate, it's very current, and we are experiencing that in response to that current trigger. When I talk about anxiety today, I'm actually talking about anxiety and fear. There are some slight differences between the two, but I'm going to group them together for the purpose of this presentation. Now, why is this important? I'm sure most of you know this already, but we know that in typically developing children, around 3 to 7% of children will experience anxiety at that clinically significant level, whereas around 20% of people with intellectual disability will experience anxiety. So we see an increase in the number of people that are experiencing anxiety as soon as somebody has an intellectual disability. When someone has autism, as we know that people with Fragile X syndrome often have autistic characteristics, that goes up to around 40% of individuals. And then when we add in some rare genetic syndromes, such as Williams syndrome, Fragile X syndrome, or Cornelia-Lang syndrome, we see that the prevalence estimates are as high as 80% of people. Now that's very, very high, and it depends on how that's measured and how the study has gone about collecting that information. Probably not as high as that in reality, but we know that there is a significant need, and families also tell us that there's a significant need for input around anxiety. Okay. So a few years ago, we conducted a research study that looked at whether we could see if we compare children with Fragile X syndrome to children that don't have a rare genetic syndrome and don't have intellectual disability, whether or not we would see that there were certain types of anxiety that people with Fragile X syndrome tended to experience. And we used a questionnaire tool, which we know there's a lot of problems with. So all of these tools have been developed for people who don't have rare genetic syndromes, and they've been normed on children without intellectual disability. So we have to be very careful about how we interpret the results that come from these sorts of studies. But it allowed us to start to ask, well, if we just have a look at the general profile of anxiety, what sorts of things do we see? Now, in comparison to children that had a significant anxiety disorder, so these are children that already had a diagnosis of an anxiety disorder, people with Fragile X syndrome scored similarly. Yeah, I can just project. I can make noise. Okay, so people with Fragile X syndrome showed a similar level of anxiety in terms of social anxiety, which is probably not new news to this group, but also in terms of obsessive compulsive disorder. Now, this may be due to the levels of repetitive behaviour that we see in Fragile X syndrome, which meant that people were triggering this diagnosis on this specific tool, but also high levels of panic disorder and specific phobias as well. Now, specific phobias you'll all be aware of, like spider phobia or fear of the dark, or being frightened of escalators, but they tend to be very specific rather than that more generalised anxiety that people sometimes report. But people with Fragile X syndrome scored lower on some of the other types of anxiety. So separation anxiety was definitely rated as lower than the clinical group, and as was generalised anxiety disorder, so that kind of generalised worry about lots of things that might happen. Now, that doesn't mean that people with Fragile X syndrome don't experience these things. It just means that they scored lower than the comparison group in this study. But it shows that there's this kind of varied profile of anxiety within Fragile X. But the problem, as I mentioned, and Kate also spoke about, is many of the measures and tools that we currently have are just not good enough to pick up the anxiety well, particularly in people with Fragile X. And what that means is that people are often overlooked, particularly in clinical services, and particularly when children have communication impairments and they might not be able to express that they're experiencing anxiety, and they might simply present with behaviours that challenge, which then get labelled as such, and they end up on a pathway of support for those behaviours that challenge, rather than targeting the underlying anxiety that might be driving those behaviours. And it can be as well that behaviours that are associated with anxiety get labelled as things that aren't anxiety. So they might get labelled as autism spectrum characteristics or other characteristics rather than that specific anxiety issue. And this has been really highlighted in some recent work that's been conducted by Laura Groves at the University of Birmingham. And she took a tool that's regularly used in clinical practice, which is the KSADS, and it's an interview measure, and she went out and spoke to lots of families about anxiety that their children and adults might experience. And she found that hardly anybody met a cut-off for an anxiety disorder on this measure, which is really odds to what has been previously reported. But what she found was that children and adults were missing out on an anxiety diagnosis because they might have missed ticking one box on this classification system that had been designed for typically developing children. And in some ways, people with Fragile X syndrome were showing a lot more elevated problems in some types, some symptoms of anxiety, which were far above what you would expect, but they weren't getting a diagnosis in a clinical service if this tool was being used, because of the fact that they weren't ticking all of those boxes. So we have a really significant issue. When she looked at the sub-threshold anxiety scores, this graph just shows the comparison between Fragile X syndrome and another syndrome group. But the important thing to take away from this is when she looked at the sub-threshold scores, we see very high rates of anxiety disorders if we treat people that are just below cut-off as potentially having anxiety, which suggests again that these tools are just not working as we hope that they would. So we have, for a number of years, colleagues at Birmingham and myself have been trying to look for behavioural signs in children and adults who use fewer words, so maybe because they have a moderate to severe intellectual disability. We've been trying to profile those behavioural signs so that we might be able to bring those behavioural signs, as well as some of the contextual variables that Kate spoke about, into a more accurate measure for detection of anxiety in people with rare genetic syndromes, and make very specific assessments for specific genetic syndromes that are tailored for those syndromes, such as Fragile X. And we've learned from the literature that there are differences and things that we can look for, such as, when people are anxious, they tend to reduce their eye contact, they tend to cling more to a familiar person, they tend to avoid certain situations. They may show increases in repetitive behaviour from their baseline. And the important thing is many tools that we currently have don't assess change from baseline. They just ask, is this behaviour present? Is this behaviour absent? They don't say, is this behaviour more than it should be for your child? And that's so important, because if we don't know that, we aren't able to pick up actually what's typical for your child and what's not, and then being able to identify children in clinical practice. So we've started to collate this information, and also making sure that the sorts of behavioural markers that we're picking up on can differentiate a person who is anxious from, say, a person who's in pain. Now, if you have a child that uses very few words, or maybe speaks in short sentences, maybe doesn't have a way to communicate or recognise when they're in pain or discomfort or when they're anxious, you can see very similar behaviours when a child is experiencing discomfort to when they're experiencing anxiety. So we need to really focus on which of the items on these tools are going to be able to tell us, okay, this looks more like anxiety, this looks more like pain, and being able to pull those groups apart. This was just a quick, I'm sure many of you have seen this study before, but this was just a quick example of one of the studies that we did in order to look at those behavioural signs of anxiety and start to validate some of those. And this was work that was done by Hayley Crawford at the University of Birmingham.
And what she did was, with adults with Fragile X syndrome, she set up 4 different situations, and she asked the person to do something different in each of those situations. So during the break situation, the person was just able to kind of get on with their tasks or whatever objects were on the table. During the photographs situation, the research assistant passed a photograph to the person with Fragile X syndrome and said, made comments on these photographs. So she would pass a photograph and she would say, I had a lovely time on holiday, I stayed in this hotel. And this provided a situation, a social situation, but one that had quite unclear social rules. So it wasn't clear whether or not the person with Fragile X syndrome should reply in that situation, whether they should just look at the photographs and put them down, or whether they should build on that conversation. So it was an instruction in a certain situation. There was also a conversation, so just a to and fro structured conversation, and a performance situation where the person was asked to read a story out loud. So each of these situations were developed to maybe create some mild anxiety and to create a situation to see whether we'd see differences across these situations and how that would impact the person. And then Hayley coded for things such as gaze length, vocal length, time to first utterance. So the first time the person was going to speak in that situation, she looked for avoidance of social interaction, signs of discomfort, and negative emotional effect, among many other things during this observation. And she found that across all of the situations, except for the break situation, anxiety was elevated in people with Fragile X, even though people showed motivation for social interaction. So they wanted to interact, but they found it very, very difficult to in those situations. And the Fragile X group on this graph is just demonstrated by the purple line, but the main thing to take away is that she was able to show that there was heightened levels of these behavioural signs of anxiety, which we are now pulling together into our current studies. So very quickly, I just now want to talk about the work that we're currently doing and where we're going next. And there are kind of 3 steps to what we're trying to do. And the first is to package up what we've learned so far and to raise awareness. Now, that isn't necessarily a research project in itself, but it's something that we need to do first, because clinicians are often not aware, even though it's been known for some time that anxiety is increased in Fragile X. Clinicians often don't know about that. And in clinical services, children may not get the assessment that they need. So we've been doing a lot of awareness raising, and we built a site called findresources.co.uk. I jot this down because basically all of the research that's come out of the University of Birmingham and now from Chris Oliver's team, and some of Kate's work is also on there, and new work may be on there soon if you want to pop it on. Yeah, so basically everything up to about 2014 that was done at the University of Birmingham is on this website. And there's lots of research papers and things that you can download, but it was designed for parents and professionals and to make it as accessible as possible for everybody. We don't believe that we should have one area for professionals that's much more complicated and another area for parents that's not, because actually all information should be accessible and available. And we've developed some training videos on that website as well around the assessment of anxiety and the assessment of behaviours that challenge. And we have some scoring manuals that have been particularly developed for assessment for people with Fragile X. So there's lots on that site. And then we have the anxiety guide as well that was developed, which includes lots and lots of strategies for management of anxiety in people with genetic syndromes more generally. And in that guide, there's some information about avoidance and how we know that avoidance potentially maintains anxiety over time, but how also to potentially intervene with avoidance. So we wouldn't ever suggest that you suddenly take your child into a situation that they find really difficult and really anxiety-provoking, because that potentially will be very stressful for them. But how to gain support and how to do that gradually, and that's all described in the guide. And there is also some information on the importance of routine and unpredictability and trying to reduce unpredictability. But as Kate noted, I can't get my words out, as Kate noted, the importance of also that kind of flexible scheduling approach and why that potentially is important when we think about anxiety is discussed in the guide, as well as strategies for increasing emotional literacy, strategies to use in situations where people might be anxious to help them regulate their emotions, and information about supporting a person to communicate and to make choices. So that's all in the guide, and I just wanted to give that a bit of a plug because most of the information so far is in there. And there's also a pain guide as well for any people that are concerned that the changes in their child's behaviour might represent underlying pain or discomfort. And I'd always suggest that you read the two guides together because they basically complement one another. And now what we're doing is we're trying to pull together, so the syndrome-specific knowledge that we've gathered over a number of years with knowledge that we have around assessments and interventions and knowledge that we have around service structure, so that we can develop syndrome-sensitive assessments for anxiety that can be used in a very short time in clinical practice. And then from there to develop syndrome-specific interventions. But identification is key, particularly in the people who are minimally verbal or use few words, because they're the people that at the moment potentially are not getting identified. So that's what we're working on. And currently we're recruiting to this study. So what we've done is similar to Kate, except with a slightly different focus, because Kate's measure is focusing on temporary outbursts associated with anxiety. Our measure is focusing on anxiety more generally. So rather than asking about signs of temporary outbursts, we're asking about signs of anxiety. And both of these studies are doing really important things that, again, potentially are very complementary in terms of taking things forward. But we're recruiting younger children or those with moderate to severe intellectual disability, so parents of those children, to complete the draft measure of the questionnaire, which we've also received feedback from parents through a development stage. And what we want to do is to get as many families to complete that as possible so that we can then work out, by following up some of those children in a more in-depth direct assessment, which of the items on our questionnaire are the ones that are most sensitive to detect anxiety, because those are the ones that we need to pull out to make the shortened clinical screening tool that we're then going to integrate into Birmingham Children's Hospital first to pilot that and then take forward hopefully to a number of other trusts. So if that's something that you think you can help with initially, it would probably take you around 40 minutes to complete. And you just need to get in touch with me or write your name down on a piece of paper after this talk so that I can follow up with you. But it would be really helpful to get as many people as possible completing that. And then we're also looking at pathways to anxiety outcomes. So some recent work by Laura Groves. She compared Cornelia de Lange syndrome and Fragile X syndrome and was asking whether something that we know is often related to anxiety in some groups, which is difficulties with inhibition, was associated. And inhibition is the ability to put the brakes on behaviour, to regulate your behaviour, to maybe switch off rumination or those thoughts that go round and round in our heads. But she was asking whether inhibition, executive functioning might be associated with anxiety. And she didn't find evidence of this in Fragile X syndrome, although that is in contrast to previous research. But the idea was that she was trying to look at what factors might lead to anxiety in the long term, because if we know what those are, we can intervene sooner for many individuals. We are now starting another study that kind of is expanding that study by looking at other potential, mechanisms that might lead to anxiety that have been shown to be important in some of the other groups we work with, including intolerance of uncertainty. So we know that people who find uncertainty difficult may be more anxious. We know that people with reflux or health-related difficulties are often more anxious as well, and that there's a relationship between pain and anxiety in a number of groups. And we're also looking at the role of sensory sensitivities in anxiety, as we've found that in some groups, being highly sensitive to the environment leads to anxiety. So again, this is a pathways project that we're currently doing, where we'll be working much more intensely with families to try to understand the outcomes for people over time in terms of anxiety. I feel like I've spoken really fast. I think I have actually spoken really fast, but hopefully that's not been too garbled and you've been able to follow that. The key things to take away is that for a number of years, you've told us that anxiety is very important. We've been trying to get better at measuring that. We think we now know how to measure it more accurately in younger children and children who are less able. So now we're pulling all those together into a clinical screening tool so that we can try and get that into services so that people are screened more quickly, but also so that clinicians are more aware of your needs at an earlier stage and can try to get interventions in place for younger children at the right time. Thank you.